all together. Hello. To our very special guest, Etienne, Dr. Du Preeze, thank you for coming and joining us and talking today. And to our guests watching on webinar, fantastic to have you. We've got a really good turnout today, so thank you very much for joining us. Just a little reminder, if you could just make sure that your microphone is on mute if you're watching from the web, that'd be great. All right, I won't hold up things anymore. Etienne, over to you. And following Etienne, we'll have Anson Xu will just join straight in and continue the presentation. All right, thanks.
Thanks. Nice spot. Yeah, thanks for having me. I think I've done 2 or 3 of these now, so it's always nice to see you guys, and thanks for always looking after patients. I'm always very happy to send patients to these clinics because I know I'm just going to get good treatment, good evidence-based treatment. I just thought a topic that's quite interesting to us because we see this a lot at our clinic and we see it a lot with the sport. I work in AFL and it's, as with most sports at a high level, we see this a lot. So we're going to talk about stress fractures of the lumbar spine, or as I say, spondylolysis. So we're going to talk about sort of the definition of what it is, some of the epidemiological factors, risk factors that you're going to look out for that's going to give you clues that it might be present, how the patient presents, what's the best way of diagnosing it, an approach to management, and how do you get them back playing sport without any further issues. So the definition of spondylolysis, we're talking about overuse injuries here, so we're not talking about an acute episode, although that being said, it's not uncommon that someone will come in going, oh, I had a big tackle or a fall and then my back hurts, and then they get diagnosed with a fracture. But usually it's actually been brewing for a while. So we're talking about a bony overload injury where with multiple repetitions, the bone slowly starts to fail and then develops a fatigue fracture or a crack. It starts with microscopic damage, and typically you'll sort of start getting pain before it actually cracks, but it's not uncommon that by the time you get the patient, they've had it for a few weeks and they already have a little crack developing. In the spine, or in the lumbar spine, we're talking about injuries to the posterolateral vertebral arch. So this is the area of interest. Now, most of them are going to occur at what's called the pars interarticularis. So that's, if you look at it from the side, it's basically the little bit of bone that's between the 2 facet joints, so between the joints interarticularis. It's the vast majority of them. You will sometimes see sort of bone stress through the pedicles. Certain sports, you'll get sort of asymmetrical load where you might get an injury to the pars, and on the other side, an injury to the pedicles, almost like a line of stress going through, especially in cricket. The most common by far is bilateral pars injuries. So there is a difference between spondylolysis and spondylolisthesis, though. So spondylolisthesis, we're referring to essentially the moving forward of one bone relative to the other, and that can occur in someone who's had bilateral pars fractures. But there are some other causes of spondylolisthesis, which I won't dwell on today. There's 4 or 5 different types. Some of them are genetic, some of them are degenerative. You'll see that in your older patients when they start getting stenosis. But for the purpose of this presentation, we're talking about spondylolisthesis as a complication of pars stress fractures bilaterally. So from an epidemiological point of view, the vast majority are going to occur at L5. So that's, when you look at an MRI, it's the first place you look, the first place you make sure it's clear before you say it's clear is the lowest vertebra, and that's just simply because it takes the most load. It's the lowest one. It's going to get the most overload. Then probably 5 to 10% of them would be at L4, and then it's quite uncommon to see them higher up, maybe in your sort of really backbendy sports, so gymnastics, dancing, where they do really extreme sort of repetitive backbends. You might see it at the high levels. Occasionally, I've seen it in a cricketer that they get it sort of at L3, but the vast majority are going to be L4 and 5. And about 80% of them are going to be bilateral. So it's you almost always assume it's going to be both sides. This is probably, I think, the most important fact today. So for anyone listening in, if you are a general practitioner, if you are seeing an active young patient complaining of back pain, it's almost 40 to 45% chance that it's a stress fracture. So there's not many conditions in medicine where the odds are that high that it's going to be something. So the take-home message, don't remember anything else. If it's an active young patient and they have back pain, get an MRI scan. I know there's a lot of education around back pain that shouldn't get imaging, and that's absolutely true for everyone else. Like an adult with back pain, most of the time it's not specific. But if it's an active young patient, it's a 40 to 45% chance they're going to have a stress fracture, so they need to be scanned. Otherwise, they end up lingering for ages. As I said earlier, it is common in pretty much every sport we're going to see. Anyone who plays at a high level, it has some level of back extension in their sport. So whether it's a running sport, a twisting sport like tennis or surfing, or a backbendy sport like gymnastics or dancing, sort of pretty much all of them are at risk. And then we talk about it being a high-risk stress fracture, that being a high risk of not healing, a high risk of delayed healing, probably not a high risk of disastrous complications, but a high risk that they might have issues later in life with recurrent back pain episodes. The pathogenesis, as I alluded to earlier, it is really one of repetitive extension that causes failure of the bone at those posterolateral vertebral arches. We think it's sort of a combination of shearing and bending forces on the bone, and probably an element of impingement between the two joints. So not only is that the narrowest bit of the bone, but you also get the sort of hinging from the joints on the bone there. So in someone older, they're going to get a bit of facet-related back pain. In someone younger, that's usually where the bone's going to fail. When we talk about a chronic non-union or a fibrous non-union, that's basically someone who's had cracks, the bone hasn't healed, and it's filled in with scar tissue, fibrocartilaginous tissue. It's not a disaster. A lot of people live normal lives and play sport at a high level with fibrous non-unions, but that's the difference in pathogenesis there. You can get a crack, you can get healing of the crack, or you can get fibrous non-union of the crack. The risk factors, firstly, it's sport. You don't see a lumbar stress fracture in a sedentary individual. It's going to be someone who's active. And certain sports, it's much higher risk. So if it's gymnastics, cricket, you almost think 80 to 90% of them with back pain are going to have a stress fracture. In certain other sports, it's probably lower risk. There are some specific sport biomechanics that are sort of designed to give a stress fracture. The best known one is cricket, fast bowlers. Pretty much every fast bowler in Australia has had one where they've had pain and they've had to sit out. So it is an occupational hazard for a fast bowler that they're going to get a stress fracture at some stage, or they're going to be picked up really early and pulled out of sport for a few months too, so they don't develop a stress fracture. Growth, these injuries do tend to occur in sort of late adolescence, and then you don't see it that commonly sort of in 20s. So once they skeletally mature, you're sort of not that worried about these injuries. There seems to be some genetics involved, as with all things. There's a gender difference, males 2 to 1 with females. There's definitely some muscle weakness and instability and inflexibilities that put them at risk. So your standard assessment is going to involve looking at their hamstring tightness and looking at their hip flexor range and looking at their hip range. So there's all the usual biomechanical issues. People with spinal deformities, so either very lordotic spines or scoliosis are more at risk. And then there's the shape of the bones can put an individual at risk. So people who've got very sort of skinny pedicles, skinny paths are slightly more at risk. So clinical presentation, firstly, they can be asymptomatic. It's not unusual to scan a 20-year-old or 21-year-old with back pain for another reason and to find that they've got chronic defects. And if you interrogate them, they can't remember really ever having had back pain before. So this will sometimes occur, probably about 10% of the time. You'll see that it's someone who can't really recall having hurt their back. The ones that we're going to see, they're going to come in presenting with pain. Typically pain in the lower back, referring into sort of the gluteal regions. Often it's one-sided. Depending on the sport they play, it'll typically be on the opposite side to their sort of dominant side. Most of the time it's insidious onset. They don't really recall when it started. They just remember it starting to hurt a bit and then gradually getting worse. It can be central, as I said, it's more common on one side. And the classic story is they say, oh yeah, I got a sore back, I rested for a week, it felt better, I went back, got a bit sore again, rested. So it typically gets better when they are resting. it's uncommon to get neurological compromise. If you are seeing someone with neurological compromise, usually means they've had a slip, that's stenosis, or there's another cause for their pain. And then night pain is uncommon, except if they've really kept pushing. If they keep playing with this for a month or two, they're eventually going to get so sore that it's going to be sore all the time. And that's often where we will see them. A kid will come in and they can't sit at school, they're sore all the time, and you pick up they've got a stressy, and as soon as they settle down for a few weeks, the pain goes away quite quickly. On examination, there's no one test that's particularly sensitive or specific, but for the most part, if you really crank them into extension, and there's various ways that you might do that depending on what they do or what sport they play, but for the most part, if you can crank them into extension on one side first and then on the other and see if that reproduces their pain, that's a reasonable test. They talk about the stalk test, which is sort of single leg, bending backwards, where you get them to really crank into that sort of posterior quadrant position, and you ask whether that reproduces their pain. When they are sore, they'll typically have pain with hopping. In the early stages, they can be painful with flexion or extension if they're really sore, but typically once the acute pain settles, you'll find that you have to really crank them into extension to provoke the pain. Not uncommon for them to be tender, and that's typically one of the last things to go as they get better, is the sort of tenderness to palpate sort of on the spinous process or on the facet joints to the side. And then, as I alluded to earlier, when you're examining them, you're going to do a little bit of a biomechanical screen. So you want to really check their posture, their postural strength, their core control, hamstring tightness, hip flexor tightness, hip range of motion, biomechanics when they're squatting and running, and all these things. So you might pick up there's some issues there that put them at risk. We'll go on to imaging. I think this is probably the best paper on the topic that was done by all the Aussie cricket practitioners. So Alex Contouris did the physio, therefore Aegis Richard Saw was the doctor for the Australian cricket team, and his wife is a researcher. So this is a really good paper that they brought out a few years ago. You'll see James Linklater was sort of the section editor. He did a lot of the reporting of the images. And they sort of talk about what's the best way to use imaging to diagnose and treat lumbar stress fractures. Take home message, MRI is the best. We'll talk about why that is. Generally, just stop doing x-rays. There's a lot of radiation. It doesn't really give us much usefulness. So for anyone joining in, don't x-ray young spines because it doesn't really help us. CT scan is even more radiation. There can be a place for that if you're unclear from MRI. We'll speak about where you might consider CT scan. And then bone scans have really gone out of fashion. There's very rarely still a reason to do a bone scan. There's a lot of radiation with that. So in this paper, they talk about the 4 goals of imaging. Obviously, firstly, you want to know whether there's bone stress. So is this player or athlete or patient presenting with pain because of bone stress? The second question is, if there is bone stress, is there a crack in the bone, or is it just sort of bone bruising? The third question is it an active stress fracture, or is it a chronic injury that's not going to heal but might have a little bit of bruising around the edges? And then the fourth question is, your fourth goal is you might look at then assessing the healing over time. So we'll get to sort of determining, but this is some MRI scans. Have you guys looked at many MRI scans for backs before? I know some of you would have looked at lots, some not so many. There's sort of two, if you can only look at 2 slices initially, you go straight to your coronal stir and your sagittal stir. Now, the problem is not all imaging practices have the same sequences. So this is Carcere Imaging's protocol that they use. If you specifically ask them for stress fracture protocol, they'll give you these images and a couple of others that I'll show you. But these are the ones that I find most useful in my practice. And sometimes if they've gone elsewhere, you don't get the same sequencing. It can actually make the decision-making a little bit harder. So check with the imaging place where you're sending them, what sequences they do. It's not unreasonable to say, include a coronal stir, a sagittal stir, and a vibe, which we'll talk about in a second. This is a great example of where you can look at the coronal stir and straight away your eyes drawn to the white bone. bone versus the other bone. So you see those ones are dark, that side is dark, that side, those ones are dark. That one immediately stands out as being brighter. And if you then look at the sagittal view of the same, we look at this little section here, that's the pars, and you look at the one above and it's nice and dark, one below nice and dark, and that level, it really lights up. And as a comparison, this is about 3 months later, where you can then see that bone, it's still very slightly bright, but has much less brightness in the bone than it was 3 months before. There you can still see a bit of brightness. So those are useful images to answer your first question, is there bone edema? The next question is there a fracture line? So this is a CT scan, showing very clearly a fracture through the pars interarticularis region. So in the past, 10 years ago, maybe you would still consider getting CT scans on these, where you see the bone edema, but the quality of the MRIs weren't so good yet, excuse me. So you would get a CT scan to see if there's actually a crack or not. Nowadays, there has been a little bit of advancement in MRI scans where they can do a special type of sequencing called a 5 sequence, which stands for something like volumetric inspirational breath hold, something. I don't remember what it stands for, but it is essentially a very a fast sequence that they do with very fine slices that's really good for 3D reconstruction, similar to a CT scan. And typically what you'll see is this sort of appearance on the 5 sequence. It's really sort of good for looking at bone. And there's a little button that I can show you on the IntelliViewers where you can actually toggle it to switch black to white and white to black. So it then essentially starts looking like a CT scan. So you'll see that compared to the previous one, you sort of end up with the same type of appearance. And that then gives you a really nice look at the bony architecture. And this is interesting. So the previous case I showed you, the initial scan, if you look closely, very, very closely, so maybe there's a little cleft just at the inferior aspect. But we sort of said, oh, it's probably more bone edema than a stress fracture. If you then scan him again at 6 weeks, and this is quite common, you then see actually he's got a crack through there. So that's another thing to be aware of in the early stages, especially at the high level where you're likely to get on top of this early, is it might look like just bone bruising. Most of the time, if you rescan them at 6 weeks, the imaging would have caught up and you'll see the crack. Because there's often that temptation to go, oh, it's just a bone bruise, we'll give you 4 weeks off, we'll get you back quickly, and then they recur at 3 or 4 months. You go, oh, gee, so now I've mismanaged it. Actually, they probably had the crack, you just didn't see it on the initial scan. The next goal, as I said, is you want to know, is it an old crack or is it a new crack? And the best way to determine that is the presence of bone edema. So if you see a fracture line, but there's no edema on the imaging, that's sort of telling you it's probably something old, probably something that's not going to heal. Where it gets tricky is you can see edema around the edges of the crack, where it could be that they've got an old defect, but because of the movement there, they're now just getting bruising around the edges. And you manage them slightly differently. And that's one of those instances where sometimes if you're not sure, you can either just be really conservative and just treat them as an active injury and see how they respond, or you can get a CT scan. That's probably one worth discussing with the doctor, because then you're sort of tossing up, is the radiation worth it? If you see edema with a fracture line, especially if it's not going all the way through, you're probably going to think it's a new or an early active stress injury. The next thing that you can do that's really helpful on an MRI scan is, if you go back to your sagittal stir, is to try and see whether someone's getting better over time. Is we can calculate what the brightness or the intensity of the bone is. And previously you sort of looked at MRI scans and you said, oh, look, it looks bright and it looks less bright, must be heading in the right direction. There's now some calculations you can do where you can actually measure the brightness. And once again, it's just something that you need to know how to do with the software. And the good imaging places will include the intensity ratios, but it's sometimes worthwhile to ask on your request to say, please include intensity ratios, especially if you are considering doing a repeat scan to see if it's getting better or not. Then essentially what you do is you measure the brightness by putting a little region of interest circle around it, and you compare it to the normal bone. and it'll give you a ratio. So the region of interest of the pars over the vertebral body, for instance, you generally want to see it be less than 2 to 1 in terms of the brightness. Anything more than 2 to 1 is probably active bone edema. And I've got heaps of examples where I looked at it and go, oh yeah, it looks much better. And then you do the ratios, it's still like 2.5 or 3 to 1. You go, oh, actually, you probably don't want to get them going too soon. They're probably still settling down. That's useful for measuring improvement. It's also at the elite level, the cricketers, what they would do is at the end of the season, they'll scan all their fast bowlers and they'll measure the intensities. And if they pick up that someone has bone edema, but it's before they've started getting sore, they'll actually heavily manage them in the off season because their data shows them that eventually they're going to get sore and eventually they're going to get stress fracture. So you've almost picked it up pre-symptomatically. Any questions with those ones at this stage? This is from that same paper. Once again, it's a cricket paper, but to summarize, the goals are, you want to know is there bone stress. So obviously, with an X-ray, you can't see bone stress. With a CT scan, you can't see bone stress. With an MRI, we definitely can see bone stress. And then with a bone scan, you can see bone stress. Okay, so MRI 1, bone scan 1. Then you want to know, is there a fracture? X-ray really unreliable, so once again, just no point doing an X-ray piece. CT scan is very useful because you can see the fracture line from early to late stage and you can measure healing. MRI is now pretty good. I would say 95% as good as CT scan. And then SPECT scan, generally, if you have it with CT, you can see the fracture line as well. So if you go through them, you'll see, look, probably the only modalities that are useful are MRI scan and bone scan. But the difference there is bone scan has got a lot of radiation and an MRI has got no radiation. And these are typically going to be young, reproductive individuals. So no real justification to do bone scans on these ones. So for the most part, your MRI is most useful. And then sometimes your CT scan is going to help you if you're not sure whether it's an old fracture or one that's going to heal. The CT scan gives you a little bit more detail on those ones. When you think of what you want to achieve, you essentially want to get them back to pain-free activity. You want to allow them to get back to their sport without getting episodes of pain the whole time. There's, in the past, lots of kids would get sore back, rest for a few weeks, play, get a sore back, and they just get through a year or two, and eventually the pain would sort of go away, and they've obviously just gone on to get a non-union. But if you look at their year or two to get there, it's probably going to be quite interrupted. They're probably going to have a lot of pain along the way. It's probably going to interfere with day-to-day function in sport. So for the most part, we want to get them better so they don't have pain so they can play their sports. We want to minimize the risk of having a recurrence. Recurrences happen probably about 30 to 40% of the time, and especially in cricket, it's about 40% of them will have recurrences. We want to minimize the risk of long-term problems, which the evidence is sort of not clear as to how much high risk they are of having persistent back pain or progression of spondylolisthesis. We don't think it's really that high, but that's one of the reasons we typically say that getting it to heal is probably still a better outcome than not having it heal. And certainly in cricket, there's good evidence that a fast bowler who heals a stress fracture is going to have a better career than one who hasn't healed. And you use the opportunities. You're going to have a lot of time where they're not going to be playing, but you can actually build them up, make them a stronger, more stable, more resilient athlete. So you can use this management period to actually work on a lot of other things. You want to identify and address risk factors, and that might just be their biomechanics or their weaknesses, or it might be some technique areas. So in cricket, they'll do a lot of bowling technique work to get them back. And then the one that's up for debate is, do we want to heal the bone? Was that sort of a bonus outcome? Is that necessary for a good outcome or not? And we'll talk about that in a second. But do we need to get the bone to heal? Cricket Australia is really the only organisation that has good data, and their data is that for a fast bowler, it probably is better to heal it. So they're very, very conservative with these. They brought out this paper in the South African Journal of Sports Medicine a couple of years ago, where they looked at what's the best way to manage bone stress injuries in fast bowlers and other athletes. And they essentially say that for a fast bowler, it probably is good to let it heal. And for other sports, we don't know. It probably is better to let it heal, but it's less clear, the evidence. The traditional approach used to be basically just manage them on their symptoms. So you give them a few weeks off, you build them back in. If they got sore again, you give them a few weeks off. I think I have, over the years, moved to giving reasonable timeframes to allow for healing, at the same time not being pedantic about it healing or not if they're going well clinically. So I think there is sort of an in-between where we're probably settling with these ones. As we said, if you get them early, 75% of them will heal, and that's probably worth aiming for initially. So I won't bore you with this one, but they're essentially going, a young athlete comes in with a sore back, they're in a sport with a lot of extension or rotation. Yes, if they've got consistent features, yes, then you proceed to, essentially saying, look, if the patient is willing to take a long period of rest, then you proceed to get some imaging and then treat it for healing. And if the patient says, no, they don't want to rest, then you just go, okay, well, we'll just go to that. We won't image them. We'll just sort of treat them symptomatically. Now, this was sort of a facetious slide in there where they said, cricket, you probably are better off trying to heal it. But, it's not completely unreasonable for an athlete to say, it's not that bad. I don't want to miss 4 to 6 months of sport. I'm just going to crack on. Like, it's not life or death sort of decisions. Why do we worry? What are the potential consequences? As I said before, I don't think it's dramatic or disastrous if they have a non-union, but we think you might have a higher incidence of pain recurring, and you have constant interruption in your training, and that could impact on that, and that can ultimately impact on your ability to get scholarships and get into teams. And so there is a knock-on effect of missing a lot of time. At the same time, you could manage someone out of that. You can say, oh, you're not doing anything for 6 months and they have no chance of selection. So you want to keep all of those things in mind. As I said, chronic fibrous non-union is a risk, could affect performance. We're not entirely sure whether it increases the risk of chronic back pain. It probably does slightly. I think someone with a spondy, certainly chronic defects, probably do get a little bit more back pain from time to time. These are two great examples of athletes who have had lots of struggles with stress fractures, who it really hasn't hampered their career. Everyone knows who's at the top. Won a gold medal in Paris, Nina Kennedy. So she was a pole vaulter, and then most people probably know who that is, Cummins. And they both got well-documented issues with this injury that interrupted their career, but they still managed to overcome it and have very successful careers. There's always a question on bracing. The answer is we don't know. Traditionally, we used to put these young athletes in braces, and then we thought, hang on, that's probably not good for their core strength. So I must say, I personally don't brace unless someone is having a lot of pain that's not settling, or they've got a really unusual fracture pattern and you want to try and get that to heal, like there's a fracture to the pedicle or something. Then you might pop them in one of these soft braces. What do we do? Like in our practice, I get MRI scans to confirm the diagnosis and to give me an indication of prognosis. Is it old? Is it new? Is it going to heal? Is it not? And is it both sides? What level, etc. If it's a chronic, then I treat them symptomatically. I probably wouldn't inject cortisone into young athletes, but if someone's got 2021 with a chronic defect that's sore, you could sometimes pop a little bit of corticosteroid into the defect to help manage their pain. But for the most part, you're just going to treat them symptomatically. You're still going to correct the risk factors. You still manage their loads, but you're going to be way less prescriptive and way less conservative than with an active stress fracture, which is this slide. If someone has a first presentation, back pain, clinically consistent, imaging shows an active stress fracture, I'm going to typically aim for healing. I'm not necessarily going to repeat imaging to check that they've healed, but I'm going to give them enough time that plausibly it could heal to reduce the risk of jumping the gun and having a recurrence. So I think time is really important with these. So I set the expectation straight away that this is 4 to 6 months. Anything quicker than that, you're probably taking more risk. Probably anything longer than that is unnecessary, but 4 to 6 months for most athletes should be sufficient time to rehab them. As I said before, it's not unreasonable for an athlete to go, no, I need to get a scholarship, the pain's not that bad, I can keep pushing, and you sort of just make sure you counsel them on the potential consequences whilst being honest that we don't know how bad it really is. What's the rehab approach? Like with most things, you want to give biological time frame. So we know it takes 3 months for the bone to heal. So your rehab needs to factor that in. But it's not uncommon that you will start them even running before they're fully healed, as long as it is healing. So what we would do at the elite level is you'd probably scan them at day 1, and you'd probably scan them around week 10 to 12 when they're starting to run, just to see which direction they're going. And if there is a fracture, but it's almost fully healed, we know it's safe to get them running. The stimulation of running will help complete the healing. It's not going to stop the healing at that point, as long as you're sensible and you've corrected all the other things. So I think the middle phase is probably the most important phase for when they need to touch base with you guys, because that's where you're going to get the most strength work, most control work in before they're going to start running, and then they're not going to really have much time for the rehab anymore. So this is the easy stage to get your young athletes doing their exercises. Once they start running and doing a bit of skilled work, they sort of lose interest in the rehab stuff. So that's where you really want to get them. And then, you know, depending on how they're going, by here you're doing some running, acceleration, deceleration, change of direction work, depending on the sport. You might start hitting if you're a tennis player. You might start batting if you're a cricketer. In cricket, they probably wouldn't let them bowl until they've confirmed healing. And then, you know, anything from week 16 onwards, you might consider getting them back playing. And during each of those phases, I like to always think of the following headings. So in that middle phase, what are you going to do for the legs in terms of building strength? What are you going to do for their trunk in terms of building core strength and control? What sort of fitness can they do? Can they run yet? And if they run, how fast and how much? And then when can you start adding some technical skills into it? So for each of those stages, you could probably sort of think through logically what they can and can't do. And it's very much going to depend on the sport that they're in. A little slide on surgery, not commonly done. I don't think I've referred someone for surgery. I've had one patient who had a really unusual fracture through his pedicle who had to get surgery. But the typical ones we see, they're either going to settle down and heal, or they're going to get a non-union and settle down. It's rare for them to have such bad ongoing pain that they need surgery. This is probably something we're going to see more and more in, say, cricket. There's a surgeon in New Zealand that has developed sort of a more minimalist surgery. It's probably a combination of a pedicle screw with a wire to sort of compress it, and they're getting a little bit more aggressive. So if they got a fast bowler with a lot of talent who's had a full fracture, they'll almost get them in off the first injury. And so far, the outcomes are pretty good, and we're starting to see a few Australian cricketers going over there as well. So at the elite level, this is a different discussion, but at the level we're seeing most of the time, you're probably not going to consider surgery. Certainly, there's lots of downsides to surgery, so we don't want to rush that. All right, that's it from me. Any questions? Anyone have any cases that were interesting or that didn't go according to plan?
It's always just a management of by the time we see these patients, it's mom, dad, and athlete, and it's a conversation trying to raise enough concern to have them take it seriously, and not so much to sort of set alarm bells off where they're really sort of over concerning it. And I think having from experience, having tests that you can do in clinic that prove the patient's getting better, because kids are either I'm fine, and then you do a similar test that before was really symptomatic, and you can tell it's still symptomatic, and then they're not. It has been having those things as like evidence, because routinely I find we don't always scan and rescan because you don't have access to it, so you are basing it off how they're performing. So having very specific things instead of like how's it going, we'll test like to the test like a specific movement that was very irritable, and then like get pulled down in terms of like getting involved in that, I guess, testing process. But that's always I find the hardest bit. It's just managing all those people at once.
And I think like what we tend to see a lot is they've already had a couple of failed attempts at return, and then it's sort of easy to get the message across going, look, this is probably, if you rush back, it's going to keep recurring, and you're just going to have that yo-yo sort of couple of seasons. It's not we're not talking now about, it's not like a bad knee injury where you've got to talk about risk of arthritis that are really real. We say, look, it's not a disastrous injury, but it's probably disastrous as far as the short to medium term goes. Like you want to be training and playing now and you're trying to get into elite teams and scholarships and stuff, it's a disaster from that point of view, because the time required is probably going to mean you miss some of those things. And I've had losses on both sides. So I've had patients where you've been too aggressive in trying to get them back and they've had a recurrence and it ends up costing them sort of another season. And then I've had patients where I've been so conservative that we've been sitting for years waiting for something to heal. Or you get, as soon as they get back, they get a bit of pain and then you see there's still a fracture. Oh, okay, we'll back you off again. I've had a patient end up missing 3 or 4 seasons. Like, he was going to go to college. He ended up sort of giving up on basketball altogether because we were waiting for it to heal and overreacting probably every time he got sore. And by the end, we just got, you know what, let's just go. Like, if it gets a bit sore, take it easy in training. And he then eventually got back and it wasn't a problem. So you can get it wrong both sides.
With the Ortho and the anti-gravity running systems, is there a protocol that we need to think about in terms of getting them back earlier, or is it something you still have to just wait?
No, I like Ortho. So I think in that middle phase there, like if you're running at 70% in the Ortho, it's probably the same stresses as walking, right? So I think in that, from sort of week 6, if someone has access to the Ortho, I'd typically start considering that. Because it just makes them feel like they're progressing. They can see the number ratcheting up every week. And it's probably good prep for them when they're running on the field. They've had a few weeks of running motion. And it does correct for a lot of your biomechanical errors when running, like the Ortho. It sort of forces you to run more in a more neutral, it's less likely to overstride or go too fast on it. So I think that's a good tool before they start running on field.
Sure. What are your thoughts on managing maybe the recovery side of things, the energy deficiency? Is a thing that you discuss? We didn't.
I purposely didn't sort of include that because that's a whole. And I think last time I was here, I did the whole thing on stress fractures. So I mean, you're always screening for these things. If someone is slow to heal or recurring, you start considering those. You start looking at their sort of intake versus their outputs.
And just given the high recurrence in the really elite athlete, do you recommend, if you've got your guys that are thinking college, at that sort of like sub-pro or pro level, do you systematically scan them after they return? Like, we'll do an end of season or an off season. Not in the patient. Once they're clear.
Yeah. I like the cricket's data is good, but even they still get 40% recurrences. So there's a big argument for, well, are you really changing anything being that strict on healing?
Yeah, so you see a little bit of bone stress in a 12-month scan. And
so they would scan them almost every 4 to 6 weeks. Right. While they're back playing, like when they get back playing, they see it. And they're pretty clever about it. They would say, okay, we're now going to introduce this volume of training. And then at 4 to 6 weeks, they scan them again to see if the bone stress is increased or it's continuing to decrease, and they almost use that as a sub-symptomatic screener for load. And that's a nice luxury to have. Yeah. But even they still have recurrences. So I think for your amateur athlete, I would rescan at around 10 to 12 weeks if I think they've had a nasty injury. So if they've got bilateral full fractures, I'm probably doing a scan before they run. If they going really well clinically and they're sort of at a lower level, I'm not that convinced that I'm going to change that outcome. As long as they take their time with their rehab, it's not going to change their outcome. I think you're more likely to slow them down with the repeat scan, and sometimes you want that. So sometimes the really elite level who's had a nasty injury, you might go, look, I don't think he's going to be back at 4 months, but you sometimes need a bit of ammunition to say, look, I know you feel really good, but this is not where it needs to be. You're going to need to add a month or 2 to the rehab.
All right, thank you.